All right, I'm going to talk to you a little bit today about ABGs. I know that we've done this in class already a couple of times, but just so we're clear on that, especially since we're getting into the ventilation and perfusion section, this is going to be even more relevant. So why? Why would we do an ABG? Well, essentially, the idea is we're trying to understand two things. We want to understand a person's oxygenation and ventilation. So how are they moving air? Is oxygen getting into their blood? And then, of course, if it's getting into their blood, obviously it should be getting to their tissues. So an acid-base balance, of course, is affected by both lungs and the metabolic system, primarily the kidneys. So we are aiming to understand the functioning of those two systems in concert. All right, so of course, oxygenation and acid base can be affected by all kinds of different things. So respiratory failure, renal failure, probably two obvious ones, but also shock, trauma, DKA, diabetic ketoacidosis, asthma, COPD, any kind of poisoning or overdose, hemorrhage, all kinds of things can affect your ABG results. Okay, so how do we do an ABG? What's the process? So we need about 1 ml of blood, and it has to be arterial blood, right? Because we're doing an arterial blood gas. Makes sense. Normally we use the radial artery, right? That's the easiest one to get to, but we can actually use any artery that we have access to. Can do it in the femoral, but the radial is usually the easiest. Also, if you have a patient that has an existing arterial line, which a lot of ICU patients will have in order to monitor their blood pressure continuously, you can actually draw that ABG out of an existing arterial line. All right, so nurses can do the test. RTs can actually draw the sample if necessary, or physicians can draw the sample, any of those people. But an RT usually is the one who runs the test. They take it to the analyzer and run it through, so you get your results. So it's nice to have one person doing the draw and then a second person ready to hand off the sample to run and take it to the analyzer quickly, because it is a little bit of a time-sensitive test, because we're measuring sort of volatile things like dissolved oxygen and dissolved CO2, right? So the sooner you can run that sample after it's been drawn, the better and more accurate your results will be. You do have to have someone hold continuous pressure on that arterial draw site for at least a minute to make sure that make sure the bleeding has stopped. All right, so here are potential locations, right? Radial artery is what we usually use. You can draw it from the brachial, or you can draw it from the femoral as well. So any one of those places. We tend to not draw it from the ulnar artery. It's a little bit harder to find and access, so we prefer that radial side. Okay, so what information do you get? And we've talked about this in class a few times, but clearly you're going to get a pH, and here are your normal values for your pH. You're going to get a PaCO2, which is the dissolved CO2 in that arterial blood. So this is different than an O2 saturation. Remember, an O2 saturation is measuring the percentage of hemoglobin that are bound to an oxygen molecule. So this is simply telling you, on the whole, what's the amount of dissolved oxygen, partial pressure of oxygen in that arterial blood sample. The same for PaCO2 is the partial pressure of carbon dioxide in the blood. There's your normal values for that. And then an HCO3, or a bicarbonate, is a direct measure of the metabolic side. So think of CO2 as measuring the respiratory side of the acid-base balance, also the acidic side. Higher CO2 equals lower pH, which means more acidic. Higher bicarbonate, which is the metabolic side of this balanced equation. Higher HCO3 that is the alkaline side. So a higher HCO3 is going to result in a higher pH or a more alkaline blood sample. Okay? Hopefully that's clear. So here's your interpretation. How do you interpret this? So first you're going to look at the pH. So you want to know, is this acidosis or alkalosis? And of course, lower numbers on the pH scale are going to be acidotic. Higher numbers are going to be alkalytic. Okay? So if you have a pure respiratory acidosis, what you're going to do next, from looking at the pH to determine if it's acidotic or alkalytic, is you're going to look at the CO2 and the HCO3 in combination. You can't really assess these independently because it'll be hard to make sense of what's going on. But in a pure respiratory acidosis, where the metabolic side has not attempted really to compensate for what's going on with the CO2, you'll have a low pH and an elevated CO2, right? In a respiratory alkalosis, you'll have an elevated pH and a low CO2. Remember, CO2, think of that as acid, right? So alkalytic blood means, and with a low CO2, you have a respiratory alkalosis. And that, of course, is with a normal bicarbonate. And then sometimes, of course, your body tries to compensate, right? So if you have a low pH and an elevated CO2, that's going to tell you, yes, we're acidotic, but that CO2 is also elevated, meaning you're retaining that acid side of the balance, but your metabolic side attempts to compensate for that acidosis, and so it elevates the HCO3, or the bicarbonate, right? And so the same would be true for a compensated respiratory alkalosis. So you know that your pH is alkalytic. Well, which one of these is pointing to the alkalytic side of the CO2 or HCO3, right? Well, the CO2 is decreased, so that's more to its alkalytic side. The HCO3 is decreased. Well, that's actually lower bicarbonate is actually moving back to the acidotic side for the pH. And so that will help you determine, is it respiratory or is it metabolic? And so you follow that process also for anything that's metabolic. So metabolic acidosis, alkalosis, and or the two compensated approaches, right? So if you can remember that CO2 equals acid, HCO3 equals base, then that will help you. So more CO2 equals more acid, less CO2 equals less acid, aka more alkaline. More HCO3 equals more alkaline. Decreased HCO3 equals less alkaline. All right, so the acronym ROAM is sometimes used as a way to help nurses remember the relationship between pH and CO2. So in a respiratory disorder, they're going to be opposite. The pH and CO2 arrows move in opposite directions. In a metabolic disorder, the pH and CO2 will move in the same direction, right? Because the respiratory system is trying to compensate. So if you see arrows, essentially, pH and CO2 moving in opposite directions, RO, then you've got a respiratory disorder. If you see metabolic equal for the ME in Rome, if you see them moving the same direction, for instance, both going down, then you've got a metabolic disorder with the CO2 trying to compensate for that problem. All right, so what do we do with this information, all right? It is great to have ABGs, but why do we care, right? They can tell you if the problem is primarily respiratory or metabolic, so that we have a place to start. What it cannot tell you is the exact underlying cause of the problem, the acid-base balance problem. It cannot tell you if this is a problem with poor ventilation, if it's a problem with poor perfusion in the lungs. In diabetic ketoacidosis, for instance, we know that that's a metabolic acidosis, but without understanding what's happening in the totality of the clinical picture, so checking the patient's blood sugar, doing some additional labs, you may not be able to understand what the underlying cause of that metabolic acidosis would be, right? So in ketoacidosis, your bicarbonate will be low. Respiratory rate will generally be high because the patient will be trying to hyperventilate to blow off additional CO2 as a way to compensate. So you're getting rid of extra CO2, the acid part of your metabolic balance. So you may actually have a disruption in oxygenation as well because of that increased breathing rate. So it can all be sort of muddy unless you look at the patient. So of course the only way to fix diabetic ketoacidosis is over the long term. You have to correct the hyperglycemia, you have to correct the electrolyte imbalances, and support the patient's renal function. So we can use the ABG along with the patient's clinical presentation to figure out how we should adjust drug treatments, sometimes ventilator settings. All that can be helpful information. But just knowing that you have a respiratory acidosis is not going to tell you exactly what you should do unless you have a good look at your patient and understand the underlying pathology. Then you can make some adjustments in their treatment. Okay, so that's the basics of ABG interpretation and then what we do with that information. Thanks.